Our next presentation and our next group of presentations is very much focused on what you in your local health districts have been doing with the funding reforms and with the health reforms that have been implemented in New South Wales over the last year or two. Our first speaker, who is an old friend of mine, indeed used to supervised me when I was a young junior medical officer at North Shore, is Professor Carol Pollock. And Carol, if you could come up and tell us what Northern Sydney's been up to.
Thanks very much, Rowan, and thanks for the invitation to discuss what our particular interests are in activity-based funding. So there are challenges in the new funding arrangements. I think nobody would dispute that. What I'm going to talk about is how the Northern Sydney local health districts have responded to these challenges, and in particular give you a board perspective on what we see as our challenge and then how we're actually making progress against them. One of the opportunities that the boards in general have had is to have some education, and we recognised the key importance of the financial education of our board. So we undertook as one of the first modules that our board looked at was the financial management and reporting module. This is the report that I get back looking at the individual capability of each of our board members, and the values are out of 5. And I'm not sure... and you can see there that there is some variability in the knowledge of our board members, but on average we score about 4.1. The average is marginally higher for the people that have been on the boards longer, and we're again marginally higher than the New South Wales average. So I think what I have to say may well be generalisable across the rest of the board membership. But I do have to say what I'm saying is largely personal, and the executive haven't been involved in the development of the presentation, just so that I don't get blamed for the content. So you'll be pleased to know I've only got 3 slides full of challenges. I think I took out the other 3 slides full of challenges. So this is half the number. So it has been interesting for the board and the executive together to develop the service and performance agreement. Previously we were given our service agreement, and I think activity-based funding being retrofitted into the budget has also been a challenge. Understanding and communicating to our broader clinical and management teams the rationale behind the nationally efficient price and then how that gets translated into the state efficient price hasn't been easy, and for people to understand how coding and translates into a nationally weighted activity unit, and the issue about how separations and cost weights interact has actually been quite challenging for the board, who largely are made up of non-medical people, to actually understand. It doesn't easily translate into commercial terms when you think of funding. And I think too that delays in coding, etc., can actually significantly under-report what your activity is, and then trying to then relate activity to budgets has actually also been challenging for the board, and it makes it difficult to own the data when the data isn't always as up-to-date as it should be. And there have been some problems with the coding, particularly in the emergency department presentations, that have made it difficult to look at how the funding matches up to the activity. We have also faced a challenge in education of the staff and their ability to take on the cost centre management is very much dependent on their understanding of it. And there is complexity in the activity-based funding. You'll see from one of the previous slides this morning, it still only accounts for about 63% of our funding. And what's in scope and what's out of scope and what's progressively becoming in scope, it's a changing field. So what was applicable this year or what was not applicable this year is now applicable next year. So developing an understanding of the widgets that make up the activity-based funding and how we might actually rejig those widgets to come up with a more efficient delivery of service is really where we've been wanting to focus our education on. And also then if we apply the ABF funding when we're outsourcing to the private or the NGO sector, has also bent the minds of the board, because as wouldn't have escaped you, I come from a local health district that's been lucky enough to have a big capital investment program, and we've just announced that we're going to be outsourcing that to the private or not-for-profit sector in our new development at the Northern Beaches. So how we actually translate our funding into their funding is also been of importance. Utilising that data to change service provision, and then utilising the data that we get from the Bureau of Health Information and other sources to inform areas where we might need to be looking and focusing our site on, and then looking at how we might interrogate these ABF buckets forensically to look at where we might be overspending, perhaps looking at where we might be shifting our incentivisation to improve service delivery. And I think one of our challenges, as was pointed out this morning, has been very cultural. I think our staff in particular have been very used to going and talking to the minister and the ministry, and I think there has been an expectation that, well, look, you know, what can we do? We can't stop them coming, therefore the ministry will just have to stump up and give us more money and bail us out. So we do have a resistance to changing the models of care, and we do have a resistance to adopting what is seen as best practice if this is how somebody has always done it. So they're my 3 slides of challenges, and that's very much truncated. So what are we doing? Well, we're doing education. Well, we're trying to roll that out across all of our sites. We did develop our hospital budgets for 2012-13 based on activity-based formula, and we have been collecting outpatient data, so we have a readiness to apply the ABF funding for outpatients in a sensible manner when that's brought in next year. And so we've been trying to incorporate ABF thinking into the service planning delivery models of care, and where we might have any opportunity to do quality projects for improvement. We have implemented a steering committee and a communication committee to try and oversee some of the recommendations that they might put in place, and we have had an increased focus on coding, and we've been doing audits, and I think everybody throughout the state has had issues relating to finding appropriately qualified coders. We certainly have. We've been looking at patient flow performance, and we have a local action plan with a whole of hospital approach to try and achieve our NEAT targets so that we get patients in and out of hospital efficiently. We have a district-wise enterprise risk management framework that includes a financial but also a performance risk framework. We have had an improvement in revenue, but it's challenging, and it's pretty much not sustainable, particularly given that we've agreed to outsource the Northern Beaches hospital to a private and not-for-profit sector. And we have developed and implemented a new program, an operational efficiency and service integration program. Now, this is my inevitable unreadable slide, and this is just outlining some of the processes that we've put in place in this operational plan that outlines key deliverables about initiating the project and then doing a diagnostic report, implementation plan, and then the governance accountability framework for each of these areas where we've identified that inefficiencies exist, and we've allocated responsibility and accountability. So the communication plan unpacks the policy, and hopefully that will assist in the engagement process, particularly with the clinicians. And we've tried to put a positive focus on it. It's not that we're looking at trying to say everyone needs to save money. That's the undercurrent, but we're trying to say that it actually will improve your ability to understand where your expenses are, where you might actually want to disinvest, as Brian highlighted. We've also had to dispel the myth that a lot of clinicians in particular thought about with ABF: if we do more, we get paid more. And that's been, quite challenging, really. What we want to do is to highlight how it actually applies to quality care, how it applies to efficiency of care. Generally, efficient care is quality care. And I think it does actually highlight transparency so that people can't argue that they're not efficient when everyone else is doing the same work with the same, if not better, outcome at a cheaper price. So I thought everyone else has mentioned hip replacement, so I threw this one in. And you can see there's a big variability in the costs of a hip replacement. And what activity-based funding does, it allows you to unpack that cost so that you might say, well, we're extremely, our prostheses cost twice as much as what the other hospitals do. Our nursing costs are twice as high. Our medical costs are twice as high. Our drug costs are twice as high. And then we go and investigate that particular bucket as to why that might be the case. And there are examples of how small changes in efficiencies can make significant changes in expenditure. And so we show some clinicians this data and they find it interesting that if you decrease your time that it takes to see a patient in ED, it actually requires fewer FTEs to see more patients, and that translates to a cost efficiency in terms of salaries. Coding, there's been a significant improvement in our coding, and that has required engagement of the clinical staff and the nursing staff and the nursing or the people that support the nursing at the clerical level. We've developed cheat sheets to allow people to code quickly and efficiently. And we've had education sessions from our coders who have been able to inform our clinicians about the value and the importance of coding. And we have had, very focused sessions for our managers on ABF. So our next steps are that we are doing more of what I've already mentioned, and we've also developed some research projects with some of our partners in the University of Sydney and the Enzyme Group to apply systems thinking to some of our activity, which in particular at the moment is our outpatients. It won't escape you that we moved to a new hospital, and that sort of has created challenges in terms of change management. So we are trying to get across some of these systems approaches to improved throughput and improved patient care. And we're also applying the new funding models in our thinking about how we're going to deliver and contract for the new Northern Beaches Hospital. So this is just one example of where we were having significant problems with bed block. This is our rehabilitation service, who were finding they were taking a long time to get patients out of the acute facility into a rehabilitation facility. You can see that there's a number of processes that they mapped that were impeding them getting out, and as a consequence of then changing small things in what's a very complex model, they were able to reduce the bed number of days that people were waiting to get to rehab by more than half. So that's being applied more broadly across other areas in the hospital. This fits into our research framework significantly, and so we're quite happy to fund that through our research funds, through our trust monies. Levers are difficult. Levers, it's a bit like the federal government who control fiscal policy, but they don't control monetary policy. We sometimes feel a bit like that. So we're working with the New South Wales pillars to try and develop some, levers that do engage the clinicians in the process, as opposed to feeling it's not their problem. We are integrating with Medicare Locals to try and improve that both admission through into a hospital and also out of a hospital, and to keeping people out of hospital through some of their programs. And we are working with some people again on research projects to try and link clinical research and financial data sets so that we can make sure that we are delivering optimal care for efficient prices. And finally, we're working on a public education program to minimise the focus on beds and refocus thinking on activity. So I'll leave it there, and thank you, Rob.